I'm Dr. Selma Calmes from Los Angeles. I'm an anesthesiologist, now retired, and I had polio as a child. I'm here to talk about polio and anesthesia. Because it's only a 20-minute talk, I won't be able to discuss the whole subject, so this will be a brief introduction to this important area for post-polio patients. My objectives today will be to review the process of anesthesia, how you get to an anesthesiologist, and what they should do. I'm going to explain what is current anesthesia practice, and I want to comment that anesthesia is constantly changing and improving. New drugs, new techniques. It's hard for us to keep up, much less patients, so don't try to do that. And then I'll talk briefly about post-polio patients having anesthesia and some particular issues for them. I got into this when I saw this symbol in a post-polio patient newsletter, and I said, what is this all about? Curare is a muscle relaxant that was used in the past. It hasn't been used for many, many years, and post-polio patients were having problems of weakness after having had curare. And this has been part of the I want to say, image of difficulty for post-polio patients. We don't use it anymore, so please don't worry about it, but I will explain something about other drugs of this type in just a minute. And as I got into this area, I decided that there was really near hysteria among the polio community about having anesthesia. And as an anesthesiologist who works with very critically ill patients and difficult surgeries, I hadn't experienced any of the issues that polio patients were reporting. For example, one of the things that's said is polio survivors are very sensitive to all anesthetic drugs. That particular day I read that, I had a patient who wouldn't wake up for many hours. This patient was Asian, and in Southern California we have many people of Asian descent. And it turns out that Asians are extremely sensitive to any sedative drugs, and this is a genetically determined issue. And there's wide variation in response to our anesthesia drugs among all patients. So this blank statement of everyone who's had polio being sensitive is really not correct. It's another issue, and it's not just due to polio. Another thing that showed up as I was exploring this area was that the incidence of post-op nausea and vomiting is much greater in post-polio patients, and the number was 30% of patients. Well, at the time that statement was written, the published incidence of post-operative nausea and vomiting in all patients was nearly 50%. And I want to just note that we do much better today because we have new drugs to prevent this problem. And the incidence of post-operative nausea and vomiting depends on the sex of the patient and the type of surgery. For example, gynecologic surgery has a much higher incidence. So the person who was writing was not communicating with anesthesiologists to find out what the situation really was. Another thing that came along was a patient said, I had a very weak leg after abdominal surgery. What can I tell the anesthesiologist next time so that he or she can prevent this? Well, it turns out this is a surgical complication. The patient had had pelvic surgery, and the retractors used to expose the pelvis can press on the nerves that are going to the leg. They're running at the back of the pelvis. And so this is a surgical complication that's well known. It's not an anesthesia complication. And many of the things that post-polio patients have reported to me have been surgical complications. And they wouldn't have heard this from the surgeon, of course. Well, how do you get to an anesthesiologist? There are several scenarios. The first would be elective surgery in a hospital. You and your surgeon decide on having surgery. You communicate your problems to the surgeon, and this would be things like a history of iron lung use as a child with polio, a history of needing ventilation as you aged, a history of sleep apnea, or a poor experience with anesthesia in the past. A surgeon's office then schedules you for the surgery, and there's a scheduling office in the hospital. And these special needs that you have are communicated at the time of the scheduling. The surgeon may also request a particular anesthesiologist. Anesthesiologists and surgeons work together daily, and so they become teams, and they like to work together, and this is very helpful for patient care. And the surgeon then might activate a pulmonary consult and evaluation of how well you breathe, or perhaps a visit to an internist. And these are very important components of getting ready for surgery. The anesthesiologist then makes a plan for what the anesthesia will be, and this is dependent on the results of some of the tests that are done. The anesthesiologist should take a brief history and physical, do a brief exam of the heart and lungs and the airway, and be sure that all the appropriate laboratory and other pre-op tests that are needed are completed and are satisfactory. And this technique of the anesthesiologist reviewing everything is done in several different ways. This is often done in a hospital's pre-op clinic, where there are scheduled appointments well ahead of surgery. And this shows the clinic in the hospital that I was chief of anesthesia in, and we used a nurse practitioner. That's common practice, and a doctor is on call to handle difficult patients and decide what tests are needed to complete the patient's pre-op evaluation. Another way of doing this is a nurse from the OR may call the patients the evening before and do a phone interview. And then they have a doctor consultant on call who can be reached if there's any question. And then the final way is at the last minute on the day of surgery, and that's very unsatisfactory for time reasons. There's not enough time to review all the tests. There's not enough time to discuss with the patient. But this, unfortunately, is common practice because of the high workload that we experience. Well, how can you be sure that the anesthesiologist you talked with preoperatively is there on the day of surgery to take care of you? Unfortunately, it's not always possible. There's a shortage of anesthesiologists and other anesthesia staff, such as nurse anesthetists. There are incoming or ongoing emergency cases that come in, and also labor and delivery may be calling for an emergency C-section. And so the OR schedule is always in flux, and there's always a shortage of manpower. Another issue is the schedule may not be made until late that evening, and so it's a very difficult problem. However, there should be a paper trail. The person who saw you in pre-op clinic or who did the pre-op call should have completed a paper that has all the results of your answers, and also be sure that all the laboratory work is available. And nearly always there's time to talk to a newly scheduled anesthesiologist before you're put to sleep or whatever technique is being used. Well, what about outpatient surgery centers? Many patients feel that they shouldn't be done in outpatient surgery centers, and I would say that's something to seriously consider, depending on your circumstances, your health, your physicians, and so on. The greatest problem comes with emergencies, such as a ruptured appendix or a car accident, and you're rushed to the local hospital. Patients should try to determine where is their local trauma center. Trauma centers are well staffed and capable of handling emergency cases. And then you figure out where you want to go if you have other emergencies, for example, a bowel obstruction. And be sure that you get the best hospital with the best staffing and the best quality of care. You might get a medic alert ID or have another way to notify hospital staff of your particular problems. For example, I keep a card in my wallet, and it's easily available if I conk out and need to be rushed to the hospital. So we've reviewed the process of anesthesia care, and this has been extremely brief. What's current anesthesia practice? I'm going to just talk briefly about some of the drugs and techniques commonly in use. And in terms of drugs, many post-polio patients in the past have focused on particular drugs. I shouldn't get this drug. But it's not the drugs, it's how they're used. And so we use many drugs. This is an example of the drugs that might be used in a particular case, an average case, lots of drugs. It's the person administering them who determines whether you're going to get into trouble with a particular drug. Excellent anesthesia depends on understanding the patient and their diseases and how they affect anesthesia. And we also need an understanding of the planned operations and its requirements. And this is one of the very fun parts of anesthesia, becoming a team with your surgeon and your nurses to give the best possible care. This is my favorite illustration. We have a patient who has diseases, post-polio syndrome and maybe diabetes or high blood pressure. You also have a history, your history of operations as a child after polio, and the resultant psychic effects, fears of hospitals, fears of difficult anesthesia inductions, and so on. And you, the patient, are interacting with what operation you're to have. And some operations need a certain type of anesthesia. And then there's the surgeon's role here. Certain surgeons can't operate under local anesthesia because they throw temper tantrums and throw instruments. And so for those surgeons, it's best if we avoid local anesthesia. And also the relationship of the anesthesiologist and the surgeon's needs plays a role here. So we're thinking about all these things and how they fit together for a particular patient coming for surgery. I'm often asked what type of anesthesia is best, and it really depends. It depends on your health, the planned operation, your anesthesiologist, and also your preference plays a role. I've had patients who had bad experiences with a spinal anesthetic, for example, and they don't want to have a spinal in the future, and it's possible for us to avoid that. I want to mention the anesthesia plan. Again, it's a required part of anesthesia care, and it should include post-op pain relief. Today we have many opportunities as anesthesiologists to help with post-op pain relief by doing various blocks. Now, different types of anesthesia, there are 3 types. General anesthesia, you're completely asleep. Regional anesthesia involves only part of the body, and MAC, monitored anesthesia care. I'm going to say a few words about regional before going to monitored anesthesia care. Only part of the body is anesthetized. This could be the lower half of you. It could be an arm, a leg, a knee. We have all kinds of tricks. The most common is spinal and epidural anesthetic. And this is where we inject local anesthesia in spaces close to the spine. An epidural, shown here, is injection of a large volume of local anesthetic, and maybe a catheter is placed also to a potential space right before the covering of the spinal canal. A spinal is an injection of a small amount of local anesthesia in the space, a fluid-filled space, right before the spinal cord. And these are very effective, especially because they block the transmission of the pain signals from where the surgeon is working to your brain. And when those signals reach the brain, then there's a response. Blood pressure goes up, heart rate goes up, and so on. And these are blocked with this technique of regional anesthesia. So it's highly favorable physiologically. What about if you have scoliosis in the back? This is in the past has prevented us from easily reaching these two spaces, but now we're using ultrasound machines, ultrasounds that are used in obstetrics or also for studies of the heart, and we can find the potential spaces, and it's been extremely satisfactory and has opened regional anesthesia to many post-polio patients. Well, should a post-polio patient have a spinal or epidural anesthetic, we're placing something in the close to the spinal cord where the disease was. I can tell you that now there are good studies, large studies of proper study form that document that there is not a worsening of your muscle weakness after having had a spinal or an epidural anesthetic. So it is safe for us, and today a common practice is to do a spinal or epidural and then put the patient to sleep. And so we have both components of relieving pain, and also the spinal or epidural can be active in the post-operative period. And this is highly beneficial in terms of patient outcome, and we're using it on all kinds of patients, so polio patients can benefit from this also. There are other types of regional anesthesia besides spinal and epidural. Another fun part of anesthesia, we can block the arm with various techniques. We can do ankle blocks, we can do toe blocks, we can do blocks of the shoulder. And these are really nifty, a lot of fun, especially now that we have ultrasound, and they're very beneficial because you, the patient, can have pain relief in the post-op period without having to take narcotic medicine. The third type of anesthetic available is called monitored anesthesia care, MAC. In this, the surgeon gives local anesthesia, and this would be a typical cataract procedure where the surgeon would do a block of the eye, and then we sedate you and monitor you. Be sure that you're comfortable. If you're not comfortable, we would step in and add additional drugs to take care of you. And this is a very accepted technique. I'm going to talk now about common operations that you may face and some of the anesthesia issues for them. Cholecystectomy is removal of the gallbladder. It's a very common operation in the United States. Today it's done laparoscopically most of the time, unless the gallbladder has become seriously infected, and then you have to have an incision. The laparoscopic approach involves a telescopic device inserted through a small incision and multiple instruments for manipulating the gallbladder, which are inserted in other small incisions. And then there's gross distension of your abdomen with an inflating gas such as carbon dioxide or nitrous oxide. And this has become the accepted technique because of improved patient outcome. This requires general anesthesia because of the distension of the abdomen. You just wouldn't be comfortable without being completely asleep. A cataract is probably the most common operation except for C-section, And it's very successful, usually only a 20-minute surgery. Again, monitored anesthesia care is the anesthetic of choice. And these are commonly done in an outpatient surgery unit. And for a post-polio patient, this is often very acceptable. Carpal tunnel is release of a band at the wrist that compresses the nerves going to the hand muscles. Again, a very common operation, especially for post-polio patients who've used crutches. And it's easily done under either straight local or various nerve blocks, and often the surgeon can do these blocks. Hand surgeons are used to working under regional anesthesia and are very competent in this area. So it's a highly successful anesthetic approach. Orthopedic procedures come in various shapes. It could be, for example, a hip fracture down to a simple knee meniscus operation. Regional anesthesia is commonly used because of the most of this is in the lower extremities, and we can use spinals or epidurals, and we're very used to that. The surgeons are used to it, and it's very safe for the patient. Rectal surgery is most often removal of hemorrhoids. Other things may be needed, but generally we're working in the bottom of the body when you sit, and it's called the saddle area. And so the most common anesthetic is what we call a saddle block. That's a spinal anesthetic with the patient sitting, and you sit for about 5 minutes after we inject the medicine, and it migrates down to the area that you sit on and anesthetizes the surgical field, and also, very importantly, it gives you post-op pain relief. This is a very painful operation afterwards. Urologic surgery, surgery of the bladder, is often done with regional anesthesia also. It's a very satisfactory technique, and also beneficial to use a spinal for transurethral resection of the prostate, because it allows us to observe your mental state during the procedure and shows us whether there's been uptake of some of the irrigating solution. That's one of the hazards of a TURP. And again, the surgeons are used to this. It's very safe for you, and I would recommend it. Shoulder surgery is nearly always done with general anesthesia in a semi-sitting position. This depends on the surgeon and the approach that they'll be using. What I want to warn you about here is it's common practice for us, the anesthesiologist, to do a block of the shoulder. We approach from the neck, and we do this before we put you to sleep. And if you have a paralyzed diaphragm, it's possible that we might take away the function of the normal diaphragm. Depends on what side is paralyzed, what side your shoulder problem is on. And so you should avoid the usual block during shoulder surgery. And I've been talking about this to anesthesiologists. Hopefully they would know about this problem. So we've reviewed the process, we've talked about current anesthesia practice. Now briefly, how do these relate to post-polio patients? There's this continuing belief that patients are sensitive to sedative medications. And I want to say that has not been my experience. I've done a lot of polio patients, and they've all woken up promptly and not had this problem. I don't know whether it's because I'm cautious in drug dosing or what, but I sense that it could be a myth. Also, I want to remind you that today we have the newer drug propofol, which is like an instant on, instant off anesthetic, and everybody wakes up very quickly after this, and this is used for everything today. And so I think that this should not be an issue in the future for you. The one thing that I can say for sure that we know is that post-polio patients are sensitive to the muscle paralyzing drugs called muscle relaxants that we give intravenously after you're asleep to facilitate some of the things that we do and also to facilitate the surgeon's work. And this has been well proved many years ago, and we still see it clinically. And there's increasing awareness of this among anesthesiologists. And you must always have monitoring of the effect of these drugs, and that's common practice. Another thing is that succinylcholine, which is a short-acting muscle relaxant, can cause muscle pain post-op in us because of the damage to our neurologic system. And succinylcholine is not used often anymore, usually only for emergency situations, because we have much better muscle relaxant drugs that end their effect in a different way. Post-op pain is thought to often be significant, and as we use more regional anesthesia in combination with general, I don't think this will be the issue that it has been in the past. The autonomic nervous system may be dysfunctional, leading to things like low blood pressure. This is due to the scarring that results from the acute polio process and some distortion of the spinal cord. The big issue that I like to communicate is respiratory issues, and it's clear that some patients who use ventilators currently, and that includes only nighttime ventilation, or who were in iron lungs for their original disease, have problems in the post-op period and need additional support, and they need maximum best care in order to recover. And we do a good pulmonary evaluation pre-op, and then you're in a site that has the highest level of intensive pulmonary care post-op, and then you can be done successfully. And to me, this calls for a major academic hospital with a real sharp care team in the ICU, which often includes an anesthesiologist. Finally, obstructive sleep apnea is another respiratory high-risk condition, and we're increasingly aware of that in anesthesia as the obesity epidemic continues and results in many more patients having obstructive sleep apnea. And so we're aware of this. You should always tell your anesthesiologist, especially if you need ventilatory support at night. And finally, laryngeal and swallowing weaknesses can show up in the post-op period. And so tell the anesthesiologist ahead of time that you have this issue, and they'll be able to handle it. Also, the ICU staff should be aware. Well, we've reviewed the process. We've talked about current anesthesia practice, and I want to say 2 years from now this may be different, and how these might relate to post-polio patients. So I hope that when you come to the OR, which looks like such a foreign and space-age environment, an environment in which we're perfectly at home, but you're not, that you'll be reassured that you'll be well taken care of. We're there. We, the anesthesiologists shown here at the head of the table, are there. We're known nationally and actually internationally as the specialty that's led the move for improved patient safety. And we've been able to document that patient safety, patient mortality during anesthesia care has improved significantly over the last 30 years. So we're here for you. You're the purpose which we exist for, and we want to do a good job. I hope you have a good experience with your anesthesia care. There's more information available about anesthesia care on the Post-Polio Health International website. Thank you.